Hello and welcome everyone to another medical update in ophthalmology, part of Hazelhurst CPD series. My name is Lydia Koenig. I am CPD Program Officer at the Central and Eastern Sydney PHN, and also working with us tonight, my colleague from CPD, Acting CPD and Events Manager, Christina Pargeter. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and pay respect to elders past, present and emerging. I'd also like to extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. Please note this event is being recorded, but due to the privacy concerns, will be available only on the individual request. This event is accredited for a total of 7.5 CPD activity hours, and will be managed on your behalf, given that all activities are completed. And now I would like to invite our facilitator for tonight and chair for this session, Dr. Janine Hopkins. Janine is local GP and GP advisor for CPD education in the Southland Shire in the South region. Thank you, Janine.
All right, thanks, Lydia. We're very lucky tonight because we've got three speakers from Retina and Eye Consultants, which are a group of 12 ophthalmologists who've all had overseas subspecialty training. And so I'd like to introduce the three of them. First, I'd like to introduce Dr. John Downie. He's a senior vitreoretinal surgeon, medical retinal specialist and complex cataract surgeon. He also has particular expertise in diabetic eye disease and is the head of the retinal unit at Sydney Eye Hospital. He trained at Sydney Eye Hospital before doing retinal fellowships in the UK at Southampton and the internationally renowned Moorfields Eye Hospital in London. And Dr. Downie was the first retinal surgeon to work and operate in Sydney South, and he's been providing care for patients here with retinal and cataract diseases since 1999. As well as Sydney Eye Hospital, also works and operates at Prince of Wales and Sydney Children's Hospital, and as well as private hospitals at Hurstville, Randwick and Chatswood. He's very passionate about teaching, and he has twice received the Trainer of Excellence Award from the College of Ophthalmologists, and he helps trains ophthalmologists both locally and abroad, including the Fred Hollows Foundation, and he regularly travels to Cambodia to teach their eye trainees. He's just come back. Last week he was actually in Fiji teaching and operating with the doctors there. So we're very glad with all his expertise that he's going to be teaching us tonight on topics such as dry eyes, eye drops and ocular trauma. And I'd like to also introduce next speaker, Dr. Nagi Assaad. He's a specialist ophthalmologist with extensive experience in cataract surgery, retinal laser treatments, intraocular injections for retinal diseases such as macular degeneration and diabetic eye disease. And during his medical school training, he also managed a research degree in visual physiology. And while working as a junior doctor, he completed a Master of Biomedical Engineering at New South Wales Uni in Advanced Optics, Ophthalmic Technology and Retinal Protein Structure. Dr. Assaad did his ophthalmology training at Prince of Wales Hospital, then did a fellowship in medical retina and uveitis at Moorfields Eye Hospital in London. He's also actively involved in teaching. He's a VMO at Prince of Wales Hospital and Sutherland Hospital, and also operates at private hospitals in Randwick and Chatswood. And he'll be talking tonight about a common problem we see in general practice, the red eye. And also, thirdly, I'd like to welcome Dr. Catriona Downie, who's an ophthalmologist specialising in oculoplastic and lacrimal surgery, ocular oncology and cataract surgery. She graduated from medicine in the University of Newcastle and completed a master's degree in clinical epidemiology at the University of Sydney. And she did her ophthalmology training at Sydney Eye Hospital. Then she went to the UK and she completed advanced fellowships in oculoplastic, lacrimal and cataract surgery at St Thomas's Hospital, London, and also gained experience in Mohs surgery and reconstruction of periocular skin cancers. She then completed a fellowship in ocular oncology at Moorfields Eye Hospital, and she gained a lot of expertise in managing ocular surface cancers and intraocular tumours. She was also involved in research and training and also the registrar training program at Sydney Eye Hospital. And tonight she's going to come along and speak to us about eyelid issues. So with the combined expertise of these three ophthalmologists, we're very grateful that they've all given up their time to come and talk to us. And I'd like you to welcome them all. Thank you very much.
So to start the session with, we're going to launch a short quiz, and I would like to welcome Dr. Catriona.
A disclaimer, the images aren't mine. just have to close that. So yeah, you've got a interesting clinic in this hypothetical afternoon. Patient number 1 comes in, and he's a 72-year-old gentleman, and he's complaining to you that he's got a gradual reduction in his vision. He's noticing he's got a lot of blur. He's had to update his spectacles more frequently than previously. And he's also noticed that he's got a bit of reduced contrast in the images that he's seeing. And so really the question for the quiz is it a cataract, yes or no? So I don't know if you know how, can put your hands up maybe, and if you think that it is a cataract, you can put your hand up, and if not, you could just leave your hand down. So it's a little bit hard not being so interactive, but these are quite typical symptoms of a nuclear sclerotic cataract. So this one is a cataract. So this is a dilated pupil showing a classic sort of nuclear sclerotic cataract. The yellowing is what contributes to the reduced sensitivity, and that sort of opacity is what contributes to the loss of visual acuity. So you've got your second patient who comes through the door. Now she's a smoker. She is in her late 60s, and she's also complaining of distortion, more so in one eye than the other. And on closer questioning, the vision loss that she's complaining of is predominantly central. And she keeps on talking, and so you found out that really she's having trouble discriminating those fine details. And her question, you know, is it a cataract for her? And so you've noticed maybe that there's slightly different symptoms compared to our previous patient. And this patient, you might not be surprised, is not a cataract. And the giveaway for her was that it's predominantly monocular, and it's the recent onset, and really that she's noticing central changes in the distortion. So for quiz question number 3, and I do apologize if anyone has seen the news recently, I made this before the very sad news about Magda Savatsky came out this afternoon. But you've got another third patient. She's complaining of reduced acuity. It has been a rapid onset, really, probably over the past couple of months. She's really struggling to drive. She's getting a lot of glare and halos, especially with the oncoming headlights, and she's blaming those new LED headlights that everyone seems to have. And she's got a vague history of some sort of trauma in the past to the eye, but she didn't have to go to hospital at the time and didn't have any surgery. And so for this patient, is it a cataract? Yes or no? And then yes, this one is a cataract, but you can appreciate that it's a slightly different appearance to the nuclear sclerotic cataract that I was talking about earlier. So this one, the slit lamp beam is oblique, and you can see the back curvature of the beam is falling on the posterior surface of the lens. And that really stippled appearance, that is what's called posterior capsular opacity or posterior subcapsular cataract. And that is because it's all of those cells proliferating along the back capsule of the cataract, and it's really causing glare and the light to scatter. And patients are more symptomatic of this in the dark, typically because of the low light sort of settings. And then your fourth patient walks through the door, and you're just having a fantastic afternoon. You've never had a better cohort of patients. They're all sort of great characters to have a chat to. And this lady tells you that she has noticed an acute reduction in her vision, predominantly in one eye, and it's been painless. And you know this lady quite well. She's been a patient for a while, and you know that she's got a past history of high blood pressure, high cholesterol, diabetes, and that she's also a smoker. And so for this patient, you might suspect from those symptoms that it's not a cataract. And this is a picture of a central retinal vein occlusion. You can see all of the intraretinal hemorrhages sort of emanating along the nerve fibers of the retina. And again, the sort of suggestion that it's not the cataract is the rapidity of the onset and the fact that it's monocular. And then this is your last patient, and he wanders in and he's got reduced vision and glare, but he's pretty sure that he had a cataract surgery a couple of years ago. He can't quite remember, and he's not sure why his vision's dropped. You know, it had been pretty good for a couple of years and now it's suddenly fallen. And he doesn't have a cataract, but what he does have, you might see that it's similar to that appearance of the posterior subcapsular cataract in the earlier question. So he has got almost like that starry night appearance of the back of the membrane of the lens bag. So you can see it on the oblique beam, which is the image on the right, and then also on the direct reflection. And that's what's causing his reduction in vision. And for him, he doesn't need to have any further cataract surgery. It's not the cataract that has come back, but some of the remaining lens fibers that were on the bag that have proliferated. And this can just be lasered off in the clinic. He doesn't need to have any further surgery. So that was the end of my walkthrough of the patients. Lydia, I don't know if you wanted to put the formal questions up and we can look at them as well.
Let's try. Sorry, I'll really close it.
Sorry,
That share the results.
Perfect. Okay, so after having gone through those 5, we've just got 2 formal questions. The first is a 70-year-old gradually worsening distance vision and difficulty reading due to glare. Could these be symptoms of cataract? Yes or no? And the second question, a 75-year-old woman presents with sudden onset distorted near vision, which began a few days ago. Could this one be a cataract? Yes or no? And then if you can click on the answers that you choose and then submit.
So that has been submitted already. We have 98% for yes answer for the first question.
Wonderful.
And we have 83% for the no answer for the second question.
I think I'd have to agree with the majority in both of those cases. It's great.
Thank you very much, Catriona. And now I'd like to pass it on to Dr. John Downie for his presentation on overview of the eye drops. Thank you.
Thanks very much, Lydia and Janine. I guess I framed the talk around dry eye because perhaps that's the most frequent reason that patients present, and also the most frequent reason for drops to be prescribed. And I guess we're all familiar with patients who come and say that they have scratchy eyes that are uncomfortable. It's often worse in the afternoons. It's often worse on a windy, dry day. It's often worse after being on a computer for a long time. And dry eye is a very common problem in our community. Maybe 5 to even 30% of people have some degree of symptoms related to dry eye. And I really wanted to make the point that it's not simply a problem of water. It's really a system problem, and that the normal lubrication of the eye reflects a combination of things. The lacrimal gland produces the fluid. The eyelids and the meibomian glands in the lids produce the lipid layer of the tear film, and the goblet cells in the conjunctiva produce the mucinous layer, which helps everything adhere. And those 3 components of the tear film have to work properly for the eye to be appropriately lubricated. And if there's a deficiency in any of those issues, then patients become uncomfortable. And so dry eye, you can think of it as a deficiency of the fluid, an aqueous deficiency, but that's actually reasonably uncommon. Or it could be evaporative. In other words, for example, there are meibomian gland problems. The lipid layer on the surface of the tear film is unstable, and therefore the fluid evaporates away. And of course, there's mixed conditions as well. And dry eye tends to be a bit of a spiral. And one thing I wanted to sort of point out is that inflammation is part of dry eye. It's not simply that there's not enough aqueous, and it works out that it's a bit of a spiral of dryness and tear insufficiency. Then the tears become hyperosmolar and irritating. They irritate the ocular surface, which becomes inflamed and then sometimes damaged, and then tear production even falls further. And the final point is that it's a chronic problem. And that's important to sort of emphasize to patients. And of course, we often use fluorescein staining to evaluate the tear film and the effect on the cornea. But I think we all look after patients with dry eye. I don't ask to see anyone with dry eyes out of choice. But we all have patients with dry eyes, and it's important to consider the patient as a whole, and there are certainly exacerbating factors which make the dryness and their symptoms worse. So, for example, working in an air-conditioned environment on a computer all day, your blink rate is much lower than normal, and so often the symptoms are worse in that situation. A lot of systemic diseases affect the lubrication of the eye, for example, Sjogren's disease and the rheumatic diseases. A lot of eyelid problems also are involved, and many medications that we all prescribe affect tear production. From the point of view of eye doctors, the glaucoma medications often affect the eyelids and cause inflammation of the ocular surface and exacerbate tear insufficiency. A lot of the psychiatric and medications, the neurology medications for Parkinson's disease have anticholinergic effects, and the SSRI medications also affect the tear film. And the same goes for rheumatology, dermatology, oncology, and even hormone replacement. All these medications have an effect on tearing, on lubrication of the eye. And so when I look at someone, it's good to just think what might be contributing to the dry eye. And so here's a chap who's got rosacea, which is a common problem associated with inflammation of the eyelid margins and ocular surface and dry eye. And the other is another patient who's got eczema, and that often goes along with eyelid inflammation and tear insufficiency as well. So these systemic diseases need to be addressed to help the tear insufficiency. The eyelids themselves, blepharitis, which is inflammation of the lid margin, is often a fellow traveller with dry eye disease, and management of blepharitis is a core baseline for managing patients with dry eye disease. And management of blepharitis, as you know, mainly centres around lid hygiene with warm saline, sometimes with baby shampoo, but the warm compresses and then the lid scrubs are the baseline of treatment of blepharitis, which often helps the tear insufficiency and those symptoms. And occasionally, if there's evidence of infection, a topical antibiotic can help. But if there's a chronic problem that's poorly responsive, sometimes low-dose tetracycline, just as it's used for rosacea, can be of benefit. And then finally, after all that, you get to considering drop treatment of dry eye, and it's a sort of vast problem. This slide is Chemist Warehouse's advertisement for Systane, which is just one brand. And if you look at all those, it's sort of impossible to sort of work out which is the best way to go and where do you start. But essentially, all these tear replacements consist of a polymer plus saline plus other buffering agents. And for example, the cystine often has hydroxypropylene. The Hylo Fresh has hyaluronic acid. And so these drops all have adherence, and it can be very difficult to work out where to start. And I'd suggest that you just get familiar with one brand, maybe. And the thing, just the principles about using drops, I think that there's often a patient preference for one brand over another, and it does reflect the fact that they all have slightly different polymers. The other issue for patients is how they use the drop, and some people will find a bottle more difficult to use than perhaps a little unit dose vial. And so those issues have got to be sorted out and explained to patients that, well, it's a bit of trial and error working out which brand might be beneficial for them. In general, it's better to use drops that don't have preservative. Also, avoid ones that have any other additives, like the old Visine or Murine used to have a vasoconstrictor, and those sort of additives are best avoided. I think generally start with the less viscous option and then move to the more viscous option. And there's a number of all the brands really have that sort of hierarchy of drop. And I think it's also important to mention to patients that the drops are not curative. They're meant to sort of help with symptoms and control, and that using them once a day is almost certainly not enough. And if they have symptoms, they need to use them frequently. And the more frequently it becomes they use the drops, it's even more important that they're non-preserved. And at night time, sometimes using a viscous agent or an ointment can be useful so that people don't wake up with eyes that just sort of feel like they're stuck together. Nowadays, in terms of controlling inflammation, sometimes a short course of a weak topical steroid can be of use, but in patients with very severe dry eye, there is a role for cyclosporin drops, which is an anti-inflammatory, which also tends to, in studies, increase tear production. But that needs to be prescribed by the PBS on authority with fairly strict criteria. The other things that sometimes come up are the use of supplements, and perhaps the most common one that I know of is called Lacritech, but basically it's got omega-3 and some omega-6 and some other supplements, and there's some soft evidence that they're of some benefit, and certainly some patients feel that they do provide relief. So it's something that could be considered, but I never strongly push these on people. And then there are other treatments, including punctal plugs, which are little occlusive devices put into the lacrimal punctum to preserve tear fill. And patients, some find them useful, but a lot find them less useful than they'd hoped. And the optometrists often will suggest this intensive pulse of light, which basically aims to close some of the little inflamed capillaries and therefore decrease inflammation. And there does seem to be some benefit for that in some people. So just in summary, Janine asked for talk about drops, but I've said it in terms of dry eye because that's a common issue. But it's to emphasize that really dry eye is a system problem, and that it needs an approach that addresses the lids and the skins and the skin, as well as the aqueous insufficiency and as well as inflammation, and that it is a chronic issue that patients need to continue to address with all the issues that go with chronic problems. Thanks very much.
Thank you very much, Dr. Downie. And our next presentation will come from Dr. Nagi Assaad on red eye. Thank you.
Thank you, Lydia, and thank you, Janine, for hosting the evening. And thanks to everyone for attending and giving us the opportunity to provide these talks. So I'll just get this up here. Is that?
Thank you.
You can see that there. Yeah. Okay. So I thought you could give a talk on red eyes, and in particular, from a GP's perspective, how do you try to work out with your limited time and resources to the equipment that we have the luxury of using to assess eyes, that in the absence of that, how do you try to assess as quickly as possible whether a red eye is something serious or can just be monitored and treated with minimal intervention. So I will start off. I'll actually discuss some of the red flags to begin with so that they're fresh in your mind when we go through the various conditions and the management of the conditions. So the first one to think of is asking the patient, they often have a sore eye as well as a red eye. Is it actually pain, or is it just irritation, like John spoke about with dry eyes, that grittiness, the feeling like there's something in the eye, or is it actual pain? Pain tends to represent inflammation in the eye or high pressures, and so tends to reflect a more serious condition. Importantly, is the vision affected? Now, if someone with dry, gritty eyes, often the vision might be a little bit blurred when the eye is dry or watery. But if vision is significantly reduced, that's important to identify and consider that this patient may need referral. Acute red eye in someone who wears contact lenses is a big red flag because of the risk of bacterial keratitis, as we'll go through later. Red eye in the setting of recent trauma or a foreign body, again, could herald something more serious. And red eye in patient who's had a history of uveitis or, say, herpetic eye disease raises the possibility that this is a recurrent episode, and so you need to consider that. You may note that what I haven't mentioned is the severity of the red eyes in terms of how red the eye is. How red an eye is doesn't necessarily tell you how severe the underlying problem is. And in fact, some of the most red eyes, like in the subconjunctival hemorrhage, are sometimes from more minor issues. So let's go through just how to do a basic assessment in a GP practice. The first step, most important, is taking a good history, and that actually can help direct you towards your goal. Firstly, asking how long has it been red for? Does it come and go? Is it constant? Is it getting worse, getting better? And how rapid is the onset? Is it one eye or both? Herpetic diseases, for example, are almost always unilateral. A viral conjunctivitis is almost always bilateral, though it can be asymmetric. As we mentioned, contact lenses, and trying to assess the associated symptoms, so decreased vision, pain, irritation, or itch. Is there a discharge? If so, is it intermittent or persistent? And also systemic symptoms like an upper respiratory tract infection or other signs or symptoms of systemic inflammatory disease, for example. Is this another episode of something that's happened before, and is there any recent trauma or surgery? In terms of a basic assessment, visual acuity is important. Pupil reactions, so if the pupil's not reactive, that sometimes could reflect angle closure glaucoma or uveitis, for example. Inspection of the eyelids and the anterior eye with whatever equipment you have. If you have loupes or if you have some sort of a magnifier then that can be helpful. But a close inspection of the eyelids and the front of the eye, and also fluorescein staining. So just a little bit of fluorescein staining. Doesn't matter so much whether you use fluorescein strips or fluorescein drops. But if you're going to use fluorescein strip, then best to put a drop of saline or a lubricant drop sample that you may have on the tip, and gently touch it onto the inner surface of the lower eyelid. So pull the lower eyelid down and tip it onto the inside surface. It's also important not to wait too long. Some people have the impression they've got to wait a few minutes for the fluorescein to soak in. That sometimes actually makes it more difficult to interpret, because the corneal epithelium starts to take up some of the stain, even in a normal eye. So put a drop in, ask the patient to blink a few times, and then have a look. This is just an example. I know John's going to speak more about trauma later on, but if you have a blue light, it can show it up really well. So this is an abrasion which without a slit lamp, without magnification, you may have trouble seeing that abrasion, but the fluorescein shows it up. Even if you don't have the blue light, a strong white light will show up an abrasion like this, or a large ulcer. In terms of the structures of the eye that can cause dry eyes, so essentially anything in front of the lens is most likely to cause a red eye. Pathology in the lens or behind it rarely causes a red eye. So we focus more on this area. And what are the structures involved in the anterior eye? So there's the eyelids. There's the conjunctiva, which includes both the internal surface of the lining of the eyelid and also the lining over the sclera. There's the sclera itself, the outer coat of the eye, and the cornea, the clear extension of that. And also the iris, which is just in front of the lens, and it's a very vascular structure, so it's prone to inflammation. So when you have someone with a red eye, think about these structures. Moving on, if we focus on this part of the eye, which is the angle, that's the one that is susceptible to closure in this condition called angle closure glaucoma, which is a very severe sight-threatening condition. And the reason it happens is because aqueous fluid flows from the ciliary body just behind the iris, through the pupil, between the iris and the lens, and into what's called the angle between the cornea and the iris. In patients who have a naturally narrow angle, which tends to happen with age over time, the angle narrows mostly due to the enlargement of the lens with cataract. But even younger people who have a naturally short eye or tend to be far-sighted are prone to this condition, that there becomes a blockage in the traffic here, and the iris gets pushed forward and suddenly snaps that angle shut, and the pressure shoots up. This tends to happen mostly in the evening when the pupil naturally dilates in the dark. So patients tend to present late in the evening with a very rapid onset, severe pain, often with nausea and vomiting. Sometimes gets confused with a neurological headache because of the severity of the headache and the vomiting. And so sometimes they're assessed in emergency with CTs and MRIs and things until it's realized that the problem is the eye. So if you look at the eye, you may see that the front of the eye is cloudy, the pupil's unreactive, it's frozen in a mid-dilated position. It's almost always unilateral, but can be bilateral, and this needs to be assessed in hospital immediately. Moving on to more common cause of red eye, which is conjunctivitis. Now, in layman's terms, we think of conjunctivitis as the viral conjunctivitis, which is usually an adenovirus, but technically, conjunctivitis can be caused by many different things, of which the most common are viral, bacterial, and allergic. And the general rule is if there's significant visual loss associated with it, if the diagnosis, the cause is unclear, or if it's persistent, then you should consider referral. So what are the various types? An adenoviral conjunctivitis, the most common type of viral conjunctivitis, but other causes of upper respiratory tract infections such as influenza, rhinovirus and COVID can cause a similar condition. There's often a history of contact with someone with conjunctivitis at home or at work. Typically, and this is almost unique to a viral conjunctivitis, is that it starts off in one eye and a few days later the second eye becomes involved. Sometimes the second eye is worse, sometimes it's not as bad as the first eye. There's often a preauricular or cervical lymphadenopathy, but reassuringly for patients, the condition resolves without sequelae in 1 to 2 weeks in the majority of cases. And so it's really just symptomatic treatment until that time. Not uncommonly, the surface of the eye can remain a little inflamed for a few weeks afterwards. And less commonly, patients can get a keratitis, which can persist for several months and cause irritative symptoms and glare. But this is always self-resolving. Bacterial conjunctivitis, perhaps not as common as we may think. It tends to be a very mild, self-limiting condition, usually only a few days. It's always bilateral, and the hallmark is they've got very persistent purulent discharge, usually not a lot of pain, and responds well to broad-spectrum topical antibiotics like Chlorcig. The exception being a gonococcal conjunctivitis, in which there is severe pain and very, very profuse discharge, which is unrelenting, and this needs urgent treatment in hospital. There's usually a suggestive history. A very common cause of red eye is allergic conjunctivitis. One of the key ways to try to assess whether it's dry eye or allergic or blepharitis or something else is ask what their predominant symptom is. And if they feel like they want to rub the eye all the time, then you have to consider that there may be an allergic component that's due to the histamine. Often the eyes are, as well as being red, are puffy and watery. They're often atopic individuals, or there've been some recent triggers like new cosmetics or using eye drops with preservatives. And usually these respond well to a topical antihistamine. Oral antihistamines also help the allergic conjunctivitis, but they also can contribute to dry eyes. Moving on to corneal diseases. So most important one that might present to a GP is a bacterial keratitis, which is a sight-threatening emergency. These are bacterial infections causing ulcers of the cornea, and sometimes they can progress very rapidly over the course of a few hours even. Contact lens wear is a significant risk factor, especially if they've left the contact lens in overnight or haven't been applying appropriate hygiene of the contact lenses. It typically has a very rapid onset. So these patients will come within 24 hours usually, and it's usually quite painful. You may see an infiltrate on the cornea without the need for a slit lamp. So you may see something as obvious as this with an overlying ulcer. They sometimes have a hypopion, which is a collection of white cells in the anterior chamber. In the less severe cases, then you may be able to see a more subtle white spot, and it's usually somewhere near the center of the cornea, and there's usually a fluorescein stain over the top of that. So that needs to be sent in to us ASAP. Usually needs quite intensive treatment. The other type of sort of a viral disease is a herpetic eye disease. And that can affect the eyes in many different ways. One common thing about them is they're typically unilateral. Sometimes in an immunosuppressed patient, they can be bilateral, but that's rare. HSV can affect really any age group. and zoster correlates with the shingles age group, which is typically older, and seems to be much more common these days. It's often recurrent herpetic eye disease, so patients need to be aware about that and present if they have any new symptoms even after the initial event. HSV tends to cause a keratitis, an ulcer, a branching, or what we call dendritic ulcer, which often will be visible without the need of a slit lamp using fluorescein. Typically presents with a persistent red eye for a few days. So as opposed to the bacterial keratitis, it's usually within 24 hours that they present. It's usually one that's grumbling along. They may have tried some allergy or dry eye drops. They may have had a course of Chlorcig, and it seems to be persisting without any improvement. And keep in mind that they may have little or no pain, unlike the bacterial keratitis, and that's because the herpes virus has reduced corneal sensitivity, and it usually responds very well to ointment, acyclovir ointment. Zoster, by contrast, tends to go through different phases and can present in different ways. At the initial time of the zoster rash in the ophthalmic division of the trigeminal, then there's often a blepharoconjunctivitis, so the eyelids are puffy and red and angry, and there can be a mild keratitis. These all respond to the oral antiviral that you would use for shingles. Important to let patients know that sometimes if they've got shingles in that region, then they can get intraocular inflammation, which is usually delayed. And so the typical thing is that as the rash is settling and their eyelids swelling is going down, then they start to, the redness of the eye starts to increase, and they get more glare symptoms. And that's because they've developed a secondary uveitis. And that usually responds to topical steroid. Very rarely, shingles can cause very severe inflammation in the back of the eye, and that presents with severe vision loss. The recurrent episodes of zoster inflammation in the eye are typically a keratitis or a uveitis. Management of herpetic eye disease is with an antiviral, either oral, sorry, that should say topical or systemic. And the damage that's done is from the secondary inflammation, and so that usually requires a topical steroid. So if you've got a high degree of suspicion, you see a dendritic ulcer, then initiating an antiviral is by all means very appropriate. But topical steroids really need to be best managed by an ophthalmologist, as sometimes you have too much and it can stir up the virus, and too little's not doing enough. Sometimes with patients with very, very frequent recurrences, we'll give a low-dose antiviral or a low-dose topical steroid as prophylaxis. Speaking of uveitis, so inflammation of the anterior uvea or the iris, either call it anterior uveitis or iritis, tends to present with pain as well as the redness, and also glare is very common. Very commonly associated with systemic inflammatory disease, which may or may not be known to the patient. Macroscopically, you might find that you just can't see the iris very well. The pupil might be irregular, and they may have a hypopia in the anterior chamber. So you may see, when I talk about an irregular iris, you may see these attachments of the iris to the lens, which can distort the pupil. And can persist even well beyond when the inflammation has resolved. And so sometimes this gives us clues. So I mentioned the correlation with systemic disease. So this is a lady that came in with something unrelated to red eye, I think flashes and floaters in her vision. I noticed that she had these nodules at the edge of her iris, and when we gave her dilating drops, you could see that they were attached to the lens. And so this represents previous inflammation, and they've got quite typical picture of what's seen in sarcoidosis. Now, she wasn't aware of being a sarcoid patient, but it was subsequently diagnosed based on this information. And so there is that very strong correlation between uveitis and systemic disease, which is important to keep in mind. This is going the other way now. So sometimes medications for other things can cause a uveitis. So this is a lady I saw a few weeks ago, 70-year-old lady who had a zoledronate infusion for osteoporosis, and 3 days later developed redness and pain of one eye. It started about 24 hours after the infusion. So this is a known side effect. It's generally very, very mild and responds well to topical steroid as it did in this case. And one thing to note is that the redness of the eye in uveitis typically is more concentrated right at the edge, just next to the limbus. It's what we call ciliary injection. So those blood vessels tend to be most affected. So if you see that, consider that there may be some uveitis. A more severe, in fact, probably the most severe form of inflammation in the eye is endophthalmitis, where is essentially a severe inflammation right throughout the eye, and it's most commonly due to recent intraocular surgery or sometimes trauma, penetrating trauma, that is. Typically presents a few days after the surgery. So the usual story is someone's had cataract surgery, their vision's getting better, and then after about 2 or 3 days, things start to get rapidly worse. And so anyone with that sort of story on its own merits urgent assessment, because any delay in treatment can really affect the outcome. And so you may see a hypopia, you may see that you can't see the iris very well because the cornea is cloudy. Sometimes the endophthalmitis comes from an endogenous source like a cardiac valve, for example, but most commonly after surgery. Other causes of red eye that are less common but important to know about: episcleritis and scleritis. So episcleritis is a layer of a tissue between the conjunctiva and the sclera, which is vascularized, and so there can be inflammation of that, which is usually not very painful and can just be a part of the eye, and usually resolves with topical medication. But again, like the story with the hepatic keratitis, it's often someone who's tried a few drops and it's been grumbling along for a few days without too much trouble, but it's just not going away. It's often associated with systemic inflammatory disease. Inflammation of the sclera, however, is a different story. So that can be very painful, and the hallmark is a very deep ache of the eye, which is unrelenting and often keeps the patient awake at night. So if someone gives you that story and they've got a red eye, then we need to think about scleritis. And when the eye is so inflamed, the sclera is so inflamed, it can sometimes change the color of the sclera and give it a more bluish underlying hue rather than the white. This is someone who developed scleritis a few days after a surgery. Again, sometimes it can be from trauma or surgery, but most commonly it's from systemic inflammatory disease like rheumatoid arthritis, and that usually requires systemic steroids and or immunosuppression. Pterygium, very common but less serious cause, and very common in Australia. Sometimes it progresses to, this is someone I operated on recently, where it is interfering with the vision because it's coming across the cornea, but sometimes it doesn't go across the cornea so much, but it can be very fleshy and inflamed and very uncomfortable, and the treatment is surgical. But only if they've got significant symptoms. It's if they're small and not symptomatic, then they can generally be left and monitored. I'll briefly mention blepharitis because we've covered it already. John's mentioned it, but it's a very common cause of red eyes, and it can manifest in different different ways, and it's often associated with other eye diseases. So it's often part of a complex multifactorial ocular surface pathology. And same with dry eyes. John's mentioned there's it's usually not just the dry eye. There's often multiple other factors which we need to consider. And finally, subconjunctival hemorrhage, which is usually the least important but most obvious of the red eyes. It's very rare that it represents any underlying serious pathology. It's usually from rubbing or spontaneous, more common in people on anticoagulants, and there's certainly no need to stop the anticoagulants based on an episode of subconjunctival hemorrhage, and always resolves, and usually we just treat them symptomatically. But if they're having very frequent episodes, and we often recommend that they have their blood pressure checked, and just keep a eye out for coagulopathies, even though it's very uncommon that they present only with subconjunctival hemorrhages. But in the setting of saying easily bruising and subconjunctival hemorrhages, then that should be considered. And the main red flag is that if they've recently had an injury where there may have been a penetration of the eye, then that's important to assess. And just would also mention this very useful, I find very useful manual for GPs and junior hospital doctors that we recommend is the ACI's Eye Emergency Manual, which is a free download, and there's also a phone app, and that covers a lot of these red flags. So thank you very much for your time.
Thank you, Nagi. And our next presentation is coming from Dr. Catriona Downie on eyelid issues in general practice. Thank you, Catriona.
Great, thank you very much. And yes, thank you again, Lydia, for having us speak to everyone tonight. We have tried to tailor our talks so that they're most relevant for you in your clinical practice. So I'm speaking tonight about eyelid issues in general practice. And this is just a brief overview of everything that we'll be touching on tonight, but mainly it sort of divides into eyelid lesions and then eyelid position problems. It's mainly case-based because it's sort of like the quiz that I did. It's just as people come through the door. This is a very common presentation that I know you see a lot in the community of someone who's got a swollen red eye. And then the difficult decision is this a preseptal cellulitis or a postseptal cellulitis? And that's really important to make a decision about and differentiate, because they're treated differently. Once an infection has extended to the postseptal space, the patient requires further investigation as well as admission for intravenous antibiotics, or at least treated through a hospital in the home sort of setup. And so these are just some of the red flags to consider. So one, I think any child that you might see who comes in with a periorbital cellulitis, if it's diffuse and not just localized to say something like a chalazion, then it does deserve consideration for referral to your local kids hospital or centre that sees children. We have a much lower threshold for treating them with antibiotics, and there's some really good pathways that have been set up to try and keep those children being managed in the community, but they're monitored daily through the hospital setting, at least through Westmead Children's. That's how they've set it up. And then, as I was saying, the decision between, is this just a soft tissue infection of the anterior tissues or is it deeper? And that all comes down to the examination, and all of those examination points are things that you don't need a slit lamp or any specialist equipment for. And so it comes down to assessing, is the infection deeper? And that is from something like pain when they're moving their eyes, or double vision. And that double vision is because of a mechanical displacement of the eye. Is there any compromise of the optic nerve, which would be because of mass effect or swelling? And you might see that with reduced vision. Or a relative afferent pupillary defect. So that's just the swinging light test. And just to, sort of go over the best way of testing that is in a dim room where you can still appreciate both of the pupils. You get the patient to look straight ahead into the distance and then try and swing a light from one eye to the other. And what you're observing is the initial reaction to that light. So if you shine a light into this eye and it constricts, and then you shine it to the other one, you would expect it to constrict. And then if you shine it back to this eye and it dilates, that is the relative afferent pupillary defect, because relative to my fellow eye, this eye has dilated, which tells you that this eye is appreciating less light. And if this was the side of the cellulitis, that would be a suggestion that it is postseptal. And then also looking at the position of the eye, the globe, if they're proptosis, if the globe has come forward. And a nice way of assessing that is to look from underneath the patient up, and you can see where their eye is sitting and where their eyelid is sitting relative to the other. And then also, you know, a giveaway is if they have any systemic symptoms, ask if they've had any recent dental work done, if they have any headache or sinus problems. If they don't have any of those things, then ECG's got a really good sort of decision matrix pathway to treat preseptal cellulitis with oral antibiotics. But I think if you've got someone who you've given 48 hours of oral antibiotics to and they're not improving, that is something that I would refer for and have them investigated further to make sure that there's not a sort of abscess or some sort of a collection that is brewing. Then moving on to benign eyelid lesions, which I know are very common and patients often notice them. And I think a lot of people are really aware of any changes in their skin. And as Australians, we've sort of been trained to monitor that. But I just wanted to talk about some of the common eyelid lesions that are benign. So this one here is a hydrocystoma. So it transilluminates. You can see that it is early and has no telangiectatic vessels. So it's just got the normal blood vessels that would normally be there, but it's just inflated and it's just from a blocked duct. Even though it's benign, it doesn't mean it shouldn't be referred. And if the patient is concerned by it, this is something that, you know, I'm happy to excise for them. And I think that a lesion being this close to the lid margin, it does sort of help to have set up. If this is something that you normally do in your practice, then the principles of the approach are just to try and excise the cyst in toto. You want to take the epithelial lining, otherwise it can keep reforming. This second lesion is a pigmented lesion. You can see it's just medial to the punctum. And what you want to know from the patient is how long has it been there for, really. And this is a nevus, but the story that the patient will tell you is that it's been there for a long time and it hasn't changed, and that's what's reassuring. If you see something like this, many patients now have got photos that you can refer back to see if it was there previously. But if there is any suggestion of growth or change, I have a low threshold to biopsy this. And then for the third picture, this is that typical appearance of a seborrheic keratosis. It's got that warty stuck-on appearance. And really the reassuring things of that are that the lashes are all still there. You can see them growing out between the lesion. They haven't lost any lashes. They haven't lost the architecture of their eyelids. So this is a benign lesion. Then the next sort of most common lesion people will come in noticing is their xanthelasma. And it's really important that they get assessed to check their cholesterol levels if that hasn't been done before. But these are benign. Again, they can be excised, but if the patient isn't bothered by them and they have normal cholesterol, then we don't have to do anything about them in particular. So these are the reassuring features of lid lesions, that they're slow or not growing at all. The normal architecture of the lid is still intact, and the lashes are a really good clue to that. So you can get loss of the lashes, or you can get misdirection of the lashes, or you can get color change of the lashes, which is sometimes they lose their pigmentation. and anything that is bleeding is a red flag. And so now to quickly go through all of the big five, if you're into safaris, of eyelid cancers. This is number one. So this is a basal cell carcinoma. And I've just popped in a couple of different images to show you that it is still quite varied. You know, this is the textbook rolled margins, umbilicated center, telangiectatic vessels, but they do look quite varied, and it depends on the subtype of the BCC, how they appear. And this one does look a little bit similar to that hydrocystoma I showed you earlier, with a couple of key differences. So one is the vessels are much juicier and there's many more of them. So this is what the telangiectasia is. And then you can also see that the lashes from here to here, they're just missing completely, and it is obliterating the architecture of the eyelids. And if you ask the patient and they had appreciated the lesion, they tell you that it's growing. The SCC is the next most common eyelid lesion. Really common, especially in this part of Sydney. There's so many people who have grown up with a lot of sun exposure and quite fair skin. They come in with this scaly lesion. And again, it's all back to the principles of assessing how the structure of the eyelid has been affected. And in these images, you can clearly see that that normal architecture has just been obliterated by the cancer. This is the scale that is typical of the keratinizing tumors. And again, you get telangiectatic vessels. So this one here, they've just ulcerated their lid margin, and up here, if we leave this one for longer, it will spread to involve the lashes. Melanoma is probably the next most common periocular cancer. Again, that is due to sun exposure predominantly when you're a child. And they are really important to pick up early around the eyelid because they're quite complicated to manage, as I'm sure a lot of you are aware. I'm not sure how many of you do skin cancer in your own practice, but the margins to excise a melanoma still have to be respected for the periocular region. So having a good diagnostic biopsy is really important, because studies have shown that a lot of periocular melanomas are upgraded on their final histology because the initial sample was too small to appreciate the level of invasion. And that means that the patient then has to have a third procedure to obtain adequate margins because they might have been inadequate on the excision. So it's the same as any other cutaneous melanoma. It's the history of growth, hemorrhage, irregular margins. Unfortunately, it's very difficult to put a dermatoscope on an eyelid, but some centres like the Melanoma Institute does have confocal, which can help in differentiating suspicious lesions. It's important that if it's a melanoma, patients need to have a sentinel node biopsy before the definitive excision is done, because the surgery to excise can disturb the response in the sentinel lymph nodes and change their staging. And then the margins for the melanoma should be 10 millimeters if possible, which, as you can appreciate, across an eyelid, that means that if you've lost 10 mils on either side, you've basically bought yourself an eyelid reconstruction, which is quite an involved procedure and involved recovery. So the earlier they're picked up, the smaller the burden of the disease is to the patient. This is the number 4, which Nagi's sort of already spoken about. This lesion here, which is a red localized swelling of the eyelid. This one is a chalazion. But this patient here has got a red localized swelling of the eyelid, but this one has persisted. And you can see that there's a little bit of destruction of that normal architecture. And this is actually what is called a sebaceous gland carcinoma. And it's a cancer of the sebaceous glands of the eyelids. And one of the principles of examining the eyelids is to check the underside. So this is a really good reminder of, if you can, to avert the eyelids and check and make sure that there's no suspicious changes on the underside. If you avert a chalazion, you just see that sort of inflamed, maybe a little yellowish area on the conjunctiva. But if you avert a sebaceous gland carcinoma, they have this sort of almost obliterative pattern of spread of the tumor. So things that should make you worry that it might be something masquerading as a chalazion is recurrence at the same site or persisting. So if it's staying there for longer than, a couple of months. And in my practice, any chalazion that I incise, I actually send the pathology to confirm that it is a chalazion and not a masquerade. Nagi did speak about pterygia. Again, they're a very common lesion that patients notice themselves and come and talk to their GPs about. This image here is a chalazion, beg my pardon, is a pterygium. So you can see that typical sheet-like growth that's coming across the cornea, whereas this lesion here is an ocular surface cancer. And it's really important to differentiate between the two because the management is quite different and needs to be, much more time pressured in an ocular surface neoplasm. And so to help differentiate between the two, you can appreciate even in this photo that it's an elevated lesion. It's got that sort of fleshy appearance. It doesn't have a dragged sheet across the cornea like the pterygium does. You can sort of appreciate that flat sheet advancing, whereas here it's heaped up and it sort of looks like it's invading into the tumor, into the stroma of the cornea itself. And then the other big giveaway is these really prominent feeding and draining vessels. So you can see there's this 3 really prominent vessels in this lesion, whereas in the pterygium, all of the vessels are about the same caliber. And then also that whiteness that you're seeing, and sometimes you can get white sort of flakes almost that sit on the top. That's called leukoplakia, and that can be a sign of the ocular surface neoplasm. So these are managed again with surgery, but it's a different surgical approach to how we take off the pterygium. And they need to be managed quite aggressively because if they spread to involve the rest of the conjunctiva, it's very challenging to preserve a healthy eye if you have got compromised conjunctiva. So these are those red flags to think of when you're seeing a patient who might have a pterygium, just, in the back of your mind to assess for these characteristics, and if they're present, to refer the patient to get them assessed. And then moving on to eyelid malpositions, I have put in ptosis first because it, of the common eyelid malpositions, this is the one that has the systemic association. And so I think anytime that I see a patient who has a ptosis, I'm always asking myself, what is the underlying cause? And so these 2 pictures both show, this woman has got a ptosis here and this woman has got a ptosis here, but one of them is quite worrying just on spec, and it's not this lady. It's this one. Even though she can see out of both of her eyes, you can appreciate that this right eye is deviated out. It's that classic down and out appearance. So the red flags to consider in any ptosis is it new? And what is the acuity of the onset of that droopy eyelid? Is there any change in the eye position? So this patient, she does have this deviation. Then ask, if you're heading down that third nerve palsy pathway, any central symptoms, any headache, history of blood pressure problems. Then assess their pupil. So is the pupil involved or not involved? And the reason that that's important is because for a third nerve palsy, it historically was used to differentiate between an aneurysm, which would compress the outside of the nerve and lead to pupil involvement by killing those fibers, versus a microvascular cause, which would affect the inside of the nerve and typically spare the pupil. Nowadays, if anyone has a concern, if you have a concern that anyone might have a third nerve palsy, I think that they deserve an urgent investigation, and we're sort of tending to image much sooner than the historical approach of waiting 3 months. So anyone who has a concern of a new third nerve palsy, I think they should go to the emergency department to be assessed. The other things that can cause a ptosis is something like a myasthenia gravis, so they present with variability and fatigability. And if you ever have someone who you think the ptosis might be related to myasthenia, there's a really simple test that you can do. And you just get an ice pack and hold it over their eyelids for 5 minutes. And it's like magic. You'll see the ptosis reverse, and their eyelid deviation, their eye deviation, if there was any, it will reverse as well. So that's a really sensitive test that's quite simple to do. And then the other thing to consider, especially in a population of, an older patient, is it giant cell arteritis or GCA? And that's where this jaw claudication comes in: temporal tenderness, loss of the pulse, change in appetite, weight loss, and they need to be referred and investigated for signs of inflammation. So we typically do that with inflammatory markers, ESR and CRP. And temporal artery biopsy is still currently the gold standard, but it looks like it's shifting towards being able to being diagnosed by ultrasound. So that's a changing space. And then other things to consider: other neurological causes is Horner's, and then rarer causes like chronic progressive external ophthalmoplegia, and then is there a lesion in the orbit that's actually causing the eye to sit forward. And then looking at other common eyelid malpositions, the entropion and the ectropion. So entropion is when the lashes are turned in. And what you want to know as a GP, if a patient comes in with an entropic lid, is the cornea safe? And so Nagi spoke about using fluorescein to assess the integrity of the cornea. So you want to know, do they have sensation, and is it already compromised? And then when I say check eyelid conjunctiva, that's averting the eyelid and making sure there's not a mass on the inside that's causing it to be pulled in. And then what can you do as a GP if you're seeing this patient and maybe you've referred them and they've not been able to be seen immediately? These are simple steps that you can take to really help the patient and to protect their eye. So start the lubricating drops or ointment that John was talking about. In this setting, I have a preference for more viscous options because they will protect the eye for longer. I tend to use Clausic ointment because if there is an epithelial defect, it will also mitigate the risk of any infection. And then you can teach the patient how to tape their lower eyelid to avert it so that you're pulling the lashes out away from the surface of the eye. And then this is the lid turning out, which is the ectropion. This is a patient who's got they both have tarsal ectropions, but this one's a more severe ectropion. This needs surgical correction if the patient is concerned by it or if there's any eye compromise. Some patients will tolerate a surprising degree of ectropion, and that's okay as long as the eye is safe. And again, similar to that last case, you just assess the sensation, the Bell's reflex, which is how their eyes roll up when they close their eyes, and then also make sure that there's no epitheliopathy. Similarly, management that you can start in the GP office is to teach them about lubricating the surface of their eye, and they can consider taping the eyelid closed at night if there's a lot of exposure, just to make sure that they have pulled the lid all the way down and the tape starts from the top corner down to their cheek to protect the eye. And that's after surgical correction. You can see that it's restored the position. So in summary, when you are faced with an eyelid lesion in your practice, consider the patient's own risk factors for having a cancer. So that comes from their skin type, immunosuppression, sun exposure, smoking status, and then looking at the lesion itself. How quickly is it changing? Has it destroyed the architecture of the eyelids? And is there any bleeding? And I think if there's any change in the architecture or bleeding or rapid growth, then it should be referred and assessed. And if it's not those things, then and the patient's confident that it's chronic, then that can be observed for a couple of months, but I would reassess them after, say, 3-4 months and make sure that it hasn't changed, just to ensure that that original assessment was right. And then this is just to remind us about the importance of checking the surface of the eye for those eyelid malpositions with the fluorescein, just to make sure that there's no epitheliopathy. And for ptosis, always consider what the underlying etiology is, and that will guide how quickly they need to be referred. If you are concerned that it's a neurological cause, they need to go to the emergency department. If you're worried about myasthenia, again, probably the emergency department. And an aponeurotic or age-related cause, they've obviously got a bit more time to be investigated. So thank you.
Thank you, Katie. And our final presentation, I'd like to invite back Dr. John Downie. Thank you.
Thank you very much for staying with us. My talk to finish the evening is about eye trauma in general practice, and it is a reasonably common presentation to general practice. And this slide is just to illustrate the fact that some arrows in the eye have greater consequence than others. In terms of evaluating trauma, you don't need to have a slit lamp. And really, equipment that you already have, a light, a magnifier, a needle, a cotton bud, and a vision chart, and a few drops let you work out what's going on. And really, the main point tonight is to say that the history is the most important thing, and the most important question is, what were you doing when it happened? What were the circumstances and the exact mechanism of the injury, as well as all the other historic important points of history? Because once you know what's happened, you can sort of expect what you might find. You can exclude some problems, and you can make sure that what you're seeing correlates with the history. For example, you'd know to ask whether this person was struck in the eye by a sun bear. And in terms of history, never trust a child. They're either too young and can't tell you, or they've been naughty and they don't want to tell you. And so with a child, you must have a greater sense of suspicion in terms of evaluating that injury. And just in terms of the history, the severity of the trauma is important, whether or not there was protection, where it occurred was important, has there been a delay, is there evidence of another injury, such as abnormal consciousness, as I said, a child. And a primary question really is, in terms of what were you doing, were you hammering metal on metal? In terms of examination, visual acuity and pupils are the most important part of any eye examination. And it's because if your vision at the beginning after an injury is better than 6/60, then there's a good chance that you'll have vision that's good, better than 6/60 in the end. If you have an afferent pupil defect, then there's only a 30% chance that you will have reasonable vision in the end. So they're by far the most important. But when I look at people, I look at, after an injury, I'm interested in their general examination, their eye movements. In other words, is there an orbital blowout fracture? And in terms of the eye exam, what's the conjunctiva like? Is the cornea normal? Is the pupil normal? And is there a red reflex? And not forgetting general findings. And as I said, the most important things are the level of vision and the pupil responses. So I just have to present, I'll go through that, present just some common things that might present to a general practice rather than perhaps to an emergency department. So the history for this person would be they were playing soccer and they got struck in the eye by the soccer ball at a close distance, and now they've got double vision. And you're all, I'm sure, seeing that the injured eye does not look up. This person has an orbital blowout fracture, so there may be pain, there may be double vision. And when you're testing, eye movements are restricted. and there's often loss of sensation over the maxilla. And the other consequence of a blunt injury that's reasonably common that you would pick up as a poor red reflex and blood in the anterior chamber is a hyphema. And if there's a hyphema, that person needs to be referred really to be seen the same day. I won't go into the other blunt consequences of blunt injury because there'll be just a whole lot of photos. But the history here would be that the person was strolling along, minding their own business, and then was caught up in a whirlwind, and they then had a sore, scratchy eye, and you can see that when the lid is averted, that there's a subtarsal foreign body, perhaps a husk of a grain or something like that, and that has been rubbing on the cornea, causing a corneal ulcer. And so it's very important to be able to avert the lid, and that lesion can usually just be lifted off with a cotton bud or similar. The history here would be something went into my eye at work, and my question to the patient would always be, well, what were you doing? And if they say they were grinding, then I feel pretty safe to know that there's not going to be an intraocular foreign body. The particle that's thrown up when people are grinding is relatively large and moves relatively slowly and doesn't go inside the globe. Then the question, after an examination is, well, how do you remove the corneal metallic foreign body that you see here? And I think the first thing to say is that the cornea is pretty tough, and that with good light, good magnification, some anesthetic, and a needle, and a cooperative patient, it's certainly something that you should feel able to do. And the principle is that you use the needle obliquely and pick off the foreign body. Now, often there'll be a rustring that remains, and that might require referral for removal at a slit lamp. And the final patient in this group is, again, someone who is at work and comes in with terribly sore eyes, watery, photophobic, usually at the end of the day, saying they were welding. And so it's what we'd call a flash burn. And when you put fluorescein in, there's diffuse punctate staining. You can see both eyes are affected, perhaps the left more than the right. That requires symptomatic care. And it really raises, these three cases in a way, raise the management of someone with a corneal epithelial defect. And I think that what I would generally do if the foreign body is removed and you're happy that there are no other issues, perhaps other than a rustring that needs to be removed, I would give local anaesthetic. I would put in antibiotic ointment, and I would use a pad, often two pads, doubled over so that the pad with tape firmly closes the eye. And the benefit of the pad is pain relief. It doesn't heal the corneal epithelial defect any faster, but it's more comfortable for the patient if the eye is held closed. Now, of course, nothing necessarily makes this sort of an epithelial defect pain-free, but a good pad and some simple analgesia and a lie down, and things are usually a fair bit better in the morning, but the patient needs to be reviewed on the next day. This is a patient who was also at work, and it said they were, cutting some conduit or some plastic pipe, but a part of the pipe fractured and it flew up and hit them in the eye. And so the patient might have not too much pain. Their vision might not be terrible either. But when you go to assess the pupil, you can see that the pupil is abnormal. It's drawn towards the supranasal aspect, and that in fact some of the iris is sticking out. So the patient has a corneal laceration with the iris prolapsed to the ocular surface, and that will require urgent referral to the emergency department, and that will require surgical repair. And just another work injury, and there's the similar presentation that this man was only young, and he said that something went into his eye yesterday, but he could still see okay. It wasn't particularly sore, but he was pretty concerned, and he went to the casualty the night before, and he said, well, look, this is what happened, and he was examined and told that things were okay. But he came to see you today because the eye is just getting a little more sore, but you check and the vision is 6/6 still, and eye movements are normal, but what you can see is some redness on the temporal side of the globe. And the important question, as I said, is what you were doing. What were you doing exactly at the time? And he was a mechanic, he was under the car, and because he was under the car, there was no space. He had to take off his goggles, and he was hammering the exhaust pipe. So this is when you look inside the eye, and you can see there's a foreign body that's bumped along the retina and finally impacted on the surface of the retina above the optic disc, and that's confirmed by the CT scan. So again, it illustrates the importance not of being able to dilate the pupil and examine proficiently in this circumstance, but of asking the most relevant question and then acting upon it. Those sort of high impact injuries are most typical of young men and working age people. Elderly people more often fall, and they often fall at night, and one of the questions or one of the problems that we see is whether the globe, when they fall and land on the eye, whether the globe itself is ruptured. Now, this is clearly not an elderly person, but this person was going off on holidays, and they were just putting the last bit of luggage on the top of their car with an octopus strap, and it didn't quite catch on the other side, and it recoiled and struck them in the eye. And their vision is, perception of light only. You can see gross swelling and hemorrhage of the conjunctiva. There is also a total hyphemia. You can't see any iris details. And this person has a ruptured globe. And you might see a very similar picture in an old person who's fallen over and landed on the side of the table. It's just to look out for those that constellation of, you can see the disorganized eye, the constellation of findings with marked conjunctival swelling and hemorrhage. There are also typically restricted eye movements, large hyphema, and if you were to test, the pressure would be low. So in that situation, you need to suspect a globe rupture, and that patient requires referral. And just to mention someone who's had a chemical injury, you most worry when the cornea is not clear and when the conjunctiva and sclera are white, and they need copious irrigation as the first step in treatment, and then referral. So I've talked about trauma in an abbreviated fashion, but I really want to emphasise the importance of history and a basic examination in working out how the patient ought to be managed. Thanks very much, Lydia.
Thank you to our three speakers who've given us really comprehensive and excellent talks. I don't think we've got any questions. I think you've actually answered everybody. But it certainly hones in the importance of eye protection, doesn't it? And the importance of doing visual acuity when we see patients. But look, thank you for some excellent talks. Also be reminded that the Eye and Retina, they also put on a very good practical procedures workshops in their rooms. So keep an eye out